It's my pleasure to introduce Charlotte Dowling, who is an osteopath at the Rice House Clinic and also a lecturer in anatomy, clinical physiology at the European School of Osteopathy. I want to hand it over to Charlotte, who's going to explain about ACT, which is acceptance and commitment therapy, and how we can use this in a pain clinic setting. Thank you, Charlotte.
Cool. Thank you. So I just wanted to say thank you to Elliot, first of all, for his new fund sending us on courses, which has been really interesting. So the course that I did was on acceptance and commitment therapy, also called ACT, and it's basically a subsection of psychotherapy that focuses on behaviour and how people behave in a given context. So there are over 4,000 models of psychotherapy, and ACT is mentioned in over 3,000 published research studies and 1,000 randomised controlled trials. It's number 2 in the evidence base, currently behind CBT, but it is under the same umbrella, and it is based on the relational brain theory, an offshoot of behaviour analysis. So we're looking at how people learn language and communication in the context of their environment. So the aims of ACT are to encourage living a meaningful life, living by your values, and making space for difficult emotions. It aims to reduce symptoms as a byproduct, but not the key aim of treatment, and to recognise coping and avoidant behaviours. So accepting what's out of your personal control and committing to action that enriches your life. So there's a few myths that are currently seen in relation to ACT. So the things that it isn't is an aim for happiness, a relaxation technique, or an aim to reduce symptoms, because there can be very meaningful things in life that aren't necessarily a cause of happiness. They could have other strong emotions. And what it is mindfulness, so paying attention to your thoughts and feelings with flexibility, openness and curiosity. It also targets problematic experiential avoidance, so avoidant behaviours that don't lead you towards a life that lives by your values. The aim is to gain control over your physical actions and acknowledge and identify difficult thoughts, feelings and memories. In the context of your behaviour. So one of the key frameworks that they work by is functional contextualism. So this is how a behaviour is functioning in the context of that person's environment. So there can be overt or observable behaviours and covert or unobservable behaviours. So either things that you can see by looking at someone or things that you can't see. So some covert behaviours would be worrying, obsessing, strategic thinking, and we want to know how that behaviour is acting in that particular context. So the context is everything that influences the behaviour that you're examining. So your genetics, social and cultural influences, interpersonal relationships, cognitive function, and it goes in 3 main steps. So there'll be a trigger that leads to a behaviour, that leads to a consequence, and the consequence is the outcome of behaviour that we either want to reinforce or reduce. They either push us towards what we want to do or they push us away from what we want to do. And another key point is that you can't over-validate someone's experience. So you want to be open, curious, and non-judgmental of what the behaviour is. So we don't make a decision as to whether the behaviour is right or wrong or good or bad. We just want to make a decision if it's leading them towards their values or away from their values. And deciding if it's going towards or away is called workability. So is this behaviour working towards your goals and towards the life you want to lead, or away from those decisions? So it's important to remember as well that we only see the context that the person presents to us in the clinic room, so they could show us one side of themselves but be completely different in another context. So we can only work with what we see and what they present to us. So what we're trying to do is alter the context of the behaviour rather than the behaviour itself.
What do you mean by that, Charlotte? To change the context rather than the behaviour itself?
So the context being how they think about that behaviour rather than necessarily what they're doing.
Like their perspective of it?
Yeah, so is it taking them towards what they want or away from what they want, but not necessarily is it good or bad. So something could be good in the short term but bad in the long term, in terms of leading them towards where they want to be, but it's not necessarily good or bad overall. So another key thing is the concept of self-acceptance and self-compassion, and that is quite often confused with self-esteem. So self-esteem is often how people view themselves based on their strengths and their achievements, but acceptance and compassion is recognising both your strengths and your weaknesses, being kind and compassionate to yourself despite your flaws. So ACT has 6 core processes that are shown in a diagram on the PowerPoint, and the core processes are aiming for psychological flexibility. So that's the ability to open up, be present, and do what matters to you. So the diagram is like a 6-pointed star, and you can start anywhere on the star as long as you're considering all 6 points of it. So the first one is self as context, the second one is diffusion, the third is acceptance, fourth is contact with the present moment, fifth is values, and sixth is committed action, and we'll go through all of those now. So there's not any strict rules for use, and you can adjust it according to each patient and what you think fits best. So I think one of the things that's most valuable to us as clinicians here is the idea of goals versus values. So values are qualities of your ongoing action, how you want to treat or approach anyone or anything, and essentially what kind of person you want to be. So they can normally be expressed in 1 to 2 words like kindness, honesty, respect, compassion, and they represent how you want to behave even when your needs aren't met, so whether they are and both when they aren't met. Slightly different to ethics and morals in that they provide more of a framework or boundaries that you live by, whereas these values are what you live by even when there's no framework given to you. Goals again are slightly different in that they are something that you want to achieve, want to have, or to get in the future. And one of the points that was given in the lectures that I watched is a goal as satisfying if the journey isn't fulfilling. So thinking about how you approach that journey rather than just a destination. So some examples of a value and a goal that are very similar would be a value is to be self-caring, to look after yourself, but a goal would be to get fit or lose weight. So it's something that you get, not how you do it. A value could be hard-working, but a goal could be have a good job. A value could be supportive, but a goal would be to provide well for your family. So we don't judge the goals or values as clinicians, we just assess whether the current behaviour is working to achieve them. So what I thought could be useful for us to do is have a look on the whiteboard about what our personal values would be versus what a patient's values would be, and see if, and the same with goals, and see if there is an overlap, or do we assume something about what their values and goals would be separate to what they actually might be. So if I write down in a diagram, like if I put CG for clinicians' goals and PG for patients' goals, and then clinicians' values, then patients' values.
No, you're good. Perfect. I'm going to set this up a bit higher just so I can get a better angle.
Yeah. So I'll just put a brief background to the case. So if we think about Mr. P, he's a 36-year-old electrician. He's booked an appointment for a flare-up of shoulder pain. It's happened many times before, usually lasts 1 to 2 weeks, and he wants to get back to work as soon as possible. So what would be our goals versus his goals?
I'll be tempted to say I'm going to center my goals around his goals, but you're not.
Yeah.
No, that's fine.
Yeah, so our goal is to, so in that context, maybe your goal is to make sure that he feels heard or listened to, so that your goals align with his goals.
Yeah, I'd also have a goal that he has I would set a goal to create a framework for him to get back into work.
Yeah.
Is that right?
Yeah.
Okay.
And what goals might he have from coming to see you?
To get back to work at ASAP?
Yeah. So he wants to get back to work. Sometimes we can assume, or I know I have assumed in the past, that someone might come in for an appointment with a flare-up and you might think that they want tools or advice on how to get themselves out of this situation in the future, and sometimes they don't necessarily want that. I don't know if you have that as well.
They just want comfort.
They just want something that day to make it go away and not think about it again. You could see that as an avoidant behaviour. They don't necessarily want to think about it happening again in the future. But it's important to recognise that not always what we assume they want is what they want.
Is it only avoidant in the context of their subjective reality? So for example, I can only say that if I was expressing the same thing, that would be me being avoidant.
Yeah.
But if they have no perspective of what they could actually potentially do, or if they have no emotional attachment to being comfortable in a week or 2 weeks or a month's time, then it's not an avoidant behaviour, it's like quite a rational goal that they've set. Is that right? Okay.
And it's also not avoidant in the fact that they've booked an appointment to address something, they haven't avoided it. So if they were to just ignore it and go to work and think it will get better, would that be more of an avoidant behaviour than them coming to the appointment in the first place? I think for us, goals is more applicable than values in terms of that situation.
Yeah, because we're more concrete, isn't it, I suppose?
Yeah, I think possibly thinking about values might be more relevant in a chronic pain presentation.
Values would be more applicable in chronic.
For
Is that
me,
because it's not self-limiting? Because acute is like you're going through this experience, how do you want to go through it? Whereas chronic is you're stuck in this experience, how do you want to get out of it?
Yeah.
Okay.
And I think more of those acute presentations versus lower level pain, but on a more consistent basis, the lower level pain becomes more ingrained into the lifestyle for a longer period of time than an acute pain does.
Okay.
But
so chronic pain has a higher chance of affecting goals and values. Is that what you're saying? Okay.
Yeah, there wasn't an absolute from the course that this 100% of the time does. But I think in the majority of cases, it's quite common that patients will come into us and say, well, I have no choice, I have to go to work or I have to look after the kids. And so we can't necessarily change the context of them having to do that work or look after the children, but we can give them tools to help control what they can do rather than worry about what they can't do.
Yeah.
Yeah. So we didn't write anything down. Interesting discussion.
Yeah.
Is there any other values that you would think or assume that a patient might have?
I'd say hardworking
Yeah.
in that situation. Like they're very conscientious.
Yeah.
What's the case study? Also,
There's a 36-year-old.
Yeah, electrician with episodic flare-up of shoulder pain. Usually lasts 1 to 2 weeks and he wants to get back to work as soon as possible.
I'd say quite tolerant as well then. Like he has this recurrent experience of pain and he just tries to deal with it as best as he can.
Yeah. And then any values that we might have as clinicians, just to think about our own philosophy towards work, not necessarily
Empowering
about
to maybe
this.
go back and sort of dance with it a little bit, see what you can do, can't do.
Yeah.
And even if there's like, I don't know, you can only do 50% of what it's normally able to do, it can kind of get them to sort of push through towards seeing what the limits are.
Yeah. Yeah.
I'd say like conscientiousness is mirrored to us as well, that we'll make ourselves accountable and then accountable for progress as best as we can.
Yeah.
But then what does this tell us? If we does this tell us how our values might marry up or differ to the patient's?
Yeah,
Okay.
I think both. And it's to think about how they might differ from a patient, but also to think about how we might approach our patients as a general rule. What is our philosophy behind how we work?
So would this come into the case history taking, that you're trying to dig for these goals and these values that they might have?
Yeah, yeah.
Okay.
And then as well, the more you might have multiple appointments, and then in those appointments more might come out,
Yeah.
which I think is quite funny. So that was number one on the, he called it the hexaflex, the 6-pointed diagram. Alright, so the next one was acceptance, and what do you think that acceptance might indicate? The
That you're
word acceptance.
Okay with the kind of, I guess, context and the way you're approaching life.
Yeah.
I would say like even the bravery, well, not maybe bravery, but the openness to face something which might be actually quite a nasty experience, like to be.
Yeah.
Okay. Just so if you like, for example, if an alcoholic can accept that they're an alcoholic, then it's not to say that they're judging themselves their way through it, but just be open to the fact that they're an alcoholic. And it gives you the opportunity for change.
Sometimes it can come across as like that you have to tolerate something, or like control over something. You just have to accept it passively, and there's nothing that you can do, like giving up type of inference. But it's mostly to do with acceptance that you might have thoughts and difficult feelings, but it's not necessarily a passive acceptance of the situation itself. So it's what you can control about a difficult situation in terms of your own views and beliefs, but you might not be able to change the situation itself. So some alternative terms that they suggested on the course that might represent that a bit better would be to lean into something, to take something with you, to make space for it, to open up as well. And the next key concept that they talked about in terms of acceptance, which we've covered a little bit already, is experiential avoidance. So the attempt to avoid or get rid of unwanted thoughts and feelings, which is very normal and very common, but high levels can cause some issues that we'll discuss in a minute. So some terms that a patient might say that might hint to you that they are experiencing avoidance are things like blocking out, pushing down, tuning out, escaping, running away from, and those are all terms that might suggest that there is something that they are avoiding dealing with at the moment. And in the course, as part of those studies that they looked at, they actually found that high experiential avoiding is related to higher anxiety levels, increased depression, poorer work performance, lower quality of life, long-term disability, more overall pathology, and drug and alcohol addictions. I don't 100% know why more overall pathology. Maybe it's the impact on the lifestyle, but those were all the things.
If someone's avoidant, but okay.
Those are all the things that they found were related to high avoidant behaviours.
What about if someone's saying they're getting used to their chronic pain? Would that be more of an acceptance approach or more of an avoidant approach because they're not doing much about it?
It depends on what the behaviour is. So if they accept it and they do what they can to deal with it. So again, coming back to the aim isn't to get rid of the pain, whether that, well, for us it would be more physical, for them, for a psychologist it might be more emotional type pain. But if they're doing things that help them cope, then that's not avoidant, because they're taking some actions to help relieve the situation. But if they just ignore it, or they do things that distract them from it, distraction is a big one, then that would be avoidant behaviour.
I see. It's more or less like the acknowledgement that's the difference.
Yeah, yeah.
Thank you.
The next point on the diagram is fusion. So fusion is when you become bonded or welded to your thoughts or feelings, and it begins to dominate your actions. So in a state, what we want to aim for is a state of diffusion, when you become separated or distanced from those thoughts and feelings, and you begin to see them for what they are. So the way that they described it in the course was that difficult thoughts and feelings are just words and images in your head, which, although they are, I think is somewhat not quite validating to our patients. Like if they came to you and you said, well, these are just words and feelings in your head, I don't think they would take that very well. But some phrases to look out for that might indicate that someone has become fused with their thoughts and feelings are feeling overwhelmed by, dominated by, swept away or controlled by, or something that's holding them back as well. So thoughts of fusion is when your thoughts and feelings become a rule to follow, or the absolute truth. It's something that feels very current even if it happened a long time in the past. And it's something that you feel you need to dedicate all of your attention to in that given moment. And when you're in a state of diffusion, they become, again, not physical thoughts and images that are in your head. You can choose how much attention you pay to them. They may or may not be true, and they're definitely not a rule that you have to follow. So they're there, you're aware that they're there, but you don't have to do what they tell you to do, or what you think you should do.
So is that the same as becoming unhooked?
Yeah.
Oh, okay.
So
you can observe them without.
Yes.
Okay.
So you have your thinking self and your observing self. So the thinking self is the thoughts and feelings that you have, but the observing self is taking a step back and having a look at those thoughts and feelings and kind of assessing them or see how they're impacting you. And in a state of fusion, a lot of people will become so welded to the thoughts and feelings that they become so ingrained in their daily life or processes that you're unaware that you're having them. They're just there.
Just out of interest, did you think about the context of patients in pain? Because it is possible to observe pain, but it can take a hell of a lot of practice and dedication and also faith to get there.
Yeah.
So did you, when you were studying these things, did you feel like, okay, that's really applicable, or was it, well, that would be really difficult to get a patient to commit to?
Commit to what part?
To commit to practicing observing their pain rather than it being.
Yeah. It's not something I've tried with the patient so far, but I think if they were open to it, then it might be quite helpful.
Okay.
So that point about the thinking self and the observing self is the next part on the diagram. And they called it the conceptualized self. So these are the thoughts and feelings that you might have about yourself, what you can or can't do, your strengths and weaknesses, and how you become who you are. So throughout your life, things might change, like your mindset, your beliefs, your physical body, but the part of you that notices the change will always be there, and that's the observing self. So that's the part that reflects or critiques the thoughts and feelings that you might have. On the course, they did an exercise called the good and bad self exercise. I don't think it's particularly applicable to us, but it is interesting to think about. So what he asked people to do was, on one side of a sheet of paper, write down all the good things that you believe about yourself, and on the other side, all the bad things that you believe. And then you hold a piece of paper quite close to you, and you see how when you're so gripped by what you believe, you can't use your hands to do anything else. And that kind of represents why that when your thoughts and feelings are so strong and you're so welded to them, that it becomes very difficult to change and be flexible with what you do. And so then he asked which side of the piece of paper is real. And the answer was that neither side is real, because you're viewing that piece of paper through your own lens. And that there isn't really a true or a false, because every person's opinion or context will be different. And so every answer will be different as to what is on those pieces of paper. So self-acceptance is realising that you aren't who you think you are, and you will always be changing. And then the last one on that diagram is committed action. So that's what we, as part of the acronym, acceptance and commitment. Commitment is what we'll look at now, committed action. So I think this again was quite applicable to what we do, so goal setting, and they run through SMART goals, but it's a bit different to SMART goals that you might have seen in that acronym before. So the S is specific action, M is motivated by values, A is adaptive, R is realistic, and T is time framed. So specific action means, and time frames sometimes go quite closely together. So an example when we're speaking to our patients is they're going to set a goal to do their rehab or their exercises. We can say, I'm going to do my rehab every day for 10 minutes, rather than I'm going to do my rehab as much as I can, because there's a quantifiable thing that you can achieve by doing it. Motivated by values, so we want to encourage patients to care for themselves and not just do something because they were told to. We want them to be invested in what they're doing for themselves. If a goal is adaptive, it will make a positive or wise difference to their life, and what we don't want it to do is something that will have no change, so no effect. And the goals need to be realistic, so they need to be in line with their resources, which might be time, energy or money. But we don't want a goal to be unachievable despite their best efforts. So one of the frames that they made to make that a bit more achievable was that you want the goal that they set to be at least a 7 out of 10 likely that they'll be able to do it in a given time frame. So if it's not a 7 out of 10 likely to do it, then you want to make the goal smaller, simpler or easier, or you might want to change it altogether. But there's no problem with reducing one big goal into smaller set goals that you can then take per time frame. And your goals want to be live goals. So he said it needs to be something that you can do better than a corpse would be able to do. So it means you need to do something that takes actions, or takes action rather than avoidant. So what do you think might be an avoidant goal?
I'm not going to go out this weekend. Is that right?
Yeah.
Because the corpse can't go out this weekend. So.
Yeah, or like pick something up off the floor or something because my back hurts. So
not pick something up.
Yeah. So they're not going to do something, and that's an avoidant goal. But what can they do? So it doesn't have to be the same thing. They can't pick something up, but they might be able to do something else instead.
So I want to choose something more suitable to do this weekend. I'm going to ask my husband or my wife to pick it up.
Yeah. That's still avoidant.
Is that still avoidant?
You're asking someone to do something, but does it help you live towards your values?
Or find a way that it doesn't hurt to pick it up off the floor.
Yeah, that would be a goal.
That's if their values are that they should be empowered in their environment to be able to do what they want.
But if their value is that I want to have a really laid back, easy life and have my family do something for me, then it would be living by their values.
Now I get the difficulty because I felt a visceral reaction to someone saying I want to live just a relaxing, quiet life.
Yeah.
And then my mind was like, no, there's so much better things you could do, and I need to make sure that's how to make sure the values are in line. Okay.
I think one of the things for us is, as a kind of natural innate thing of how we've come into this job or into this industry, a lot of us will value health quite highly, but our patients might not necessarily value health.
Yeah.
So we've got to make sure that we're doing something that is realistic for them to do to help them live a meaningful life, rather than imposing our values onto them.
Oh, so I'm having to look at myself now.
Yeah, sometimes I say like it's like eating your veggies. Like you just got to do it sometimes.
Yeah.
Like I kind of relate to myself. Well, I hate stretching personally.
Yeah.
So I just figure out a way to make it fun for myself.
Yeah.
So I actually get it done, and that's it.
What are you saying then? That's you understanding your own values, but also understanding. Yeah, that's difficult now, because now we're having to balance what is an objective reality, which is that it is better if you do this, even though your values don't. Then that's a difficult.
It's because we're not judging the values, so it might be objectively better for health.
Yeah.
But we don't judge whether their value of not viewing health as a value is good or bad.
But then if their values don't lead them to what would be an objective outcome, which is linked to their goals, how do we go about that then?
So if they don't...
There's something that they want, which their values and their goals aren't going to take them there.
Yeah. So then you have to ask them to reflect on things. So if you want this goal, but what you're doing at the moment isn't going to take you there, what can you do in terms of your behaviour that will put you more on that path?
So can you embellish in or commit to a behaviour which isn't reflective of your values or your goals?
I guess you could. They didn't really put that as a specific situation, but if you...
But then that's a conversation you have with the patient.
Yeah.
Say that even though your values and your goals aren't leading you in this direction, these are the objective things that would.
Yeah.
And then
the thing is that their values are sort of kind of leading them away from pain anyway, because they've kind of made the step to look us up, pay the money, get here, block some time out of the day.
Yeah.
So there's like a crossover.
Yeah.
Oh, okay.
So maybe there's no goal there, but it says that they have the whole value, but maybe they don't see how it could look.
Well,
like representing that value in their life.
Okay.
The other thing that's quite interesting to consider is whether someone is driven by going towards something or away from something. So if you have someone come in and, for example, they've got hip pain, are they being driven towards something, like I want to be able to go out and do a 10k walk every Saturday, or are they being driven away from something that I want to avoid a hip replacement, and then taking them on that journey and seeing how you can achieve those goals. Again, in that situation, there will probably be quite a big overlap in terms of what you do and discuss with them. But again, it's more of an action-driven behaviour or an avoidant-driven behaviour, even though the goal is effectively the same thing, to get rid of their hip pain.
Cool.
So after you've set a goal with them, it can be helpful to discuss what unhelpful things is your mind saying about this goal and any uncomfortable feelings that have showed up. So is what unhelpful things might be, this is going to be really painful, or I'm not going to have time to do that. Any other ones that you think?
Can't be bothered to do that. I've been in pain for so long, why would I bother trying?
Can't do it. Time, I guess. Said that already.
Also, like a lot of people don't, they struggle to differentiate between different types of pain, like pain of stretch or pain of worked muscle versus pain. Is that right? Is that what you're asking? Like those?
Or just things that, so it's, what barriers might they come up with to achieving their goals?
It might hurt more afterwards.
So belief systems and like that. So these are and resources in terms of SMART goals could come into here as well. So time, money, attention span, mental health, emotional budget, like all this kind of, okay.
So then you might need to go back and revise the goal that you've set according to the things that they've come up with, so that it is 7 out of 10 level of achievable.
Mm-hmm.
So we'll come back to belief barriers and how to address them in a minute, but there is a corresponding diagram as well, so the opposite of the first one we looked at, which shows the consequences of inflexibility. So dominance of the conceptualized self, past and future, limited self-knowledge, so limited awareness of the self, of the observing self. Lack of values or clarity or contact with your values. Unworkable action, so action that's not going to take you towards where you want to be. Attachment to the self and fusion, so being fused with your thoughts and feelings, and then experiential avoidance as well. So then we'll move on to some exercises. Again, some of them are more applicable than others. So I've tried to pick the ones that I think are most relevant. So the first one is the ACE formula, which stands for acknowledgement, connection and engagement. And you can do this using the dropping anchor metaphor, which you might have come across before. Yeah. So effectively, dropping the anchor means you're holding steady as the storm comes and goes, so as difficult feelings come and go. You're not able to control the storm, but you're able to control how you sit within it and go towards your goal. So the first step is to acknowledge what do you notice in terms of thoughts, feelings and memories, what's coming up. Connect, so connect with your body. It might be to stretch, move, or maybe some deep breaths. And just remind yourself that there's a body around the thoughts and feelings that you are able to control. And then the last step is to engage. So look around the room, think about your senses, where are you, what are we doing here, and what we're going to work towards in the session.
These are grounding techniques.
Yeah, except it's not quite the same as grounding. I think traditionally grounding is more of a distraction technique.
Okay.
Whereas with this, you must do the A part, so the acknowledgement part is quite key. You have to recognise what those thoughts and feelings are that are difficult and causing the internal storm. So we've got to turn towards the difficult things and not away from them.
Mm-hmm.
It is quite useful as a circuit breaker when someone's feeling quite overwhelmed, and you can do it from anywhere from 15 seconds to 15 minutes, just go by how each patient takes it, and you can do it as many times in a row as you need to. And again, you can do the ACE formula in any order, but again, you just have to make sure that the A is included. And the reason that they say that this is not a distraction technique is because it's compassionate to the self and compassionate for us as clinicians to recognise the pain that someone is having rather than to distract them from it. Quite often patients will have used distraction techniques at home for many, many years before they decide to actually address the problem. So it can be useful as well to debrief after doing this. Do they feel more present? Do they feel like they've got more control over their actions? And maybe ask them how this could be helpful outside of the clinic room. And if they can't really answer, it would be good to guide them, otherwise they won't really apply it at home. So ask them if they would be willing to practice this outside of the room, and again set a goal with it, when, where, how often. And ask them to recognise what coexists with the pain, so that the pain isn't the key focus, it's something that you acknowledge.
What do you mean by that?
So it would be more to do with how they can move their body. So for us, if it was back pain, the back pain is there, but what else can you do with your body that coexists with that pain comfortably? And that would come back to the connect step of it.
So ACE is accept, connect and?
Acknowledge, connect and engage.
Acknowledge, connect and engage.
So an example of that be sort of, I've had a bit of a flare on, and I can't quite do what I want to do to get myself out of pain, and then maybe doing a little bit all they can do.
Yeah, and you can do it just as simply as sitting in the chair, and they could just move their body in a way that feels good. That isn't associated necessarily with the pain, but the pain is still there. It doesn't have to be anything that takes too long. You can just sit and do it at any time. So, similar to the good self and bad self exercise on a piece of paper, the next one is called hands as thoughts and feelings. You can do it with a piece of paper or you can do it with your hands. So on one side of the room, you look towards everything that is important to you, whether it's good or bad or pleasant or painful, and then take your hands and put them together, and depending on how close they are to you, it kind of represents the level of fusion that you've got. So the closer they are is the more fused you are with those thoughts and feelings, and the closer they are, the more difficult it is to see everything or see the bigger picture. And again, it comes back to your hooked violin. So they might ask how this is going to solve a problem, and again, the thing is, some problems can't be solved, like if it's grief or they're dealing with something difficult. You can't change what's happened in the past, but you can change your action and decide how closely hooked or fused you are with those thoughts and feelings. For us as a clinic room, I don't really know if we would bring that one in necessarily, but it might be something that a patient could consider doing at home.
I guess a teacher is not to be overwhelmed by what's going on, just not be able to do something, and that the whole idea of like your negative thoughts are sort of just pictures.
Yeah.
So if you're overwhelmed by something, it's just a context or state of mind you have at the moment.
Yeah.
And then kind of detaching from it a little bit, maybe.
Yeah.
Yeah.
And
it's tough enough.
that thoughts and feelings as pictures was another thing that they went through. So steps towards diffusion or becoming separated from them. Some things they suggested was singing the thought that you have in a funny voice in your head, or visualizing the thought.
So this is unhook. This is
Yeah.
process. Yeah. So okay.
So taking the power out of something negative because you're almost making light of it.
Yeah.
At the same time. You could visualize the thought as black text on a screen in your head, and then change the colour, change the font, change the gaps in between the letters, and suddenly it's just become a thought that you've got, not a really intense feeling.
Is this based on this concept of psychological flexibility?
Yeah.
Oh, okay. And it once again reinstates you as the observer rather than the thought.
Yeah.
So then unhooks you. Okay.
So you're physically then observing it.
Yeah.
In the sense that you can see it rather than feel it.
Understand.
And again, patients might come back and say it's not working, what's the point, the thoughts and feelings are still there, and you just come back to the beginning and say that the aim is not for those thoughts and feelings to go away completely, it's just to change how you view them and what you do when you have them. And again, steps to foster diffusion and encourage psychological flexibility. So to notice, name, normalise, find purpose, and then workability. So when you notice, you use phrases like, I notice I'm having a thought that, or I'm having the thought of something, and then you name the thought, so what is it that you're feeling? Normalise, so from us we could say that it's normal and natural to have difficult or unhelpful thoughts. And then find a purpose, so the mind isn't your enemy or your friend, it just is the mind, and it's always trying to solve problems. So to either avoid or access something that will help this situation. So when you're worrying, your mind is helping you prepare for the worst or avoid failure. Self-judgment, so you're avoiding social rejection. Rules and reasons provide safety, certainty, and structure in uncertain contexts. And all of these things are helping you to stop making the same mistake again that you might have made in the past, or that you viewed as a mistake in the past. And then the final step, workability, is to assess where does this take you. Does it take you towards your goal or away from your goal? And if it takes you away, how are we going to address that? What can we do differently? So the illusion of controlling thoughts is something else that they discuss. So there will always be common phrases or idioms, for example, that you could never quite forget the end of. Like if someone said it's raining cats, then you would always think it's raining cats and dogs. So you can't delete those things from your brain. They might always be there. But what you can do is add things on top of that, change the context or change how you view them. And that's effectively what we're doing with the thoughts and feelings, adding different things on top of what's already there to make it more manageable. And just like being told not to think about something makes you think about it more, it's the same with those thoughts and feelings. We're not taking them away, but we're taking the power out of them instead.
Do you think that's true with pain as well? Like that you could ever get some, I suppose they do, don't they? There's a lot of patients who are chronic pain specialists who work with patients to accept that pain will always be there, but it's not going to be as much of a limiting factor as we're going to work for it to become less of a limiting factor for your life.
Yeah,
okay.
yeah. So
Yeah, like using the word sensitivity has been really powerful and sort of empowering
Yourself,
because it reassures them that there's no damage, nothing's broken.
Yeah.
It's just super sensitive.
And that's contextualising it differently, isn't it?
Yeah.
Okay.
Yeah. So coming back to that functional contextualism, how we learn our language and communication, and how does that impact our environment, or how are we shaped by our environment? I think the clinic room in itself is an environment, and we can shape how someone thinks about themselves or about their pain, about their body in that environment. This is quite common for people to come in and say, if we talk about some beliefs that people might have about their bodies, like for someone with low back pain, what are the common beliefs that they might share?
Like a 7-year-old, or something slipped, or it's busted.
My back's weak, it's vulnerable.
If I was a dog, it would put me down. I hear that a lot.
Yeah, and all of those are thoughts and feelings that they have that might not necessarily go away, but what are they doing to change that, or what are they doing to address those thoughts and feelings? Are they doing any strengthening? Are they doing any movement? And that's what we can change with the context. We might not always change their mindset, but we can change their environment of that belief.
It's almost like covertly making that maladaptive belief just useless then, or giving it so much evidence to the contrary that you can still have it if you want, but you're probably going to come to your own conclusion that it was never right to begin with, or that it wasn't ever. Okay.
And I think as well that's useful when that belief is so ingrained, or they're so fused with that belief. If you just tell them the opposite, they might not respond in the way that you would hope. They might not just accept that. Because it's such a big part of their context.
Okay. So would it be confrontational? If someone said that I feel like my back's weak, and you said, okay, what are you doing anything to strengthen it? Would you go down that line of questioning to?
I think it depends on the person.
Okay.
I think for a lot of people it would come across as confrontation. But we do ask them what are they doing, and in the context when we ask for aggravating and relieving factors, we're already kind of assessing what they're doing, to change that.
I found sometimes asking why they feel that way, or what makes them feel that way, kind of gets them to like vocalise all the feelings, all the information they have. And a lot of the time it is just, it just feels that way, and I kind of just move on rather than pushing back so much.
And again, similarly, but it might work, it might not. When someone says those beliefs and they say, but it's true, I am weak, or I am old, or I am getting fatter. If the patient gets stuck in this hexaflex model, you move on to another part of the model, you kind of accept that that's their belief for now. But remind them that we don't spend time deciding if those things are true or false, or good or bad, we just decide what we can do about them when those feelings are present. And then you can ask them a magic wand question. So if I could wave a magic wand and these thoughts and feelings disappear, what would you do differently? So quite often they'll say something along the lines of, I'll eat better, or focus on my nutrition, move more. And when you ask them then why they're not already doing those things, quite often there won't be a big barrier to address. And then the final exercise is more of a journaling type exercise called Making the Link. So you can provide a few questions to the patient, like when you get hooked with your feelings, what do you get pulled towards or away? What behaviours begin to emerge, like do you pull away socially, or do you move towards coping through other mechanisms like alcohol? And what consequences does this have? Do you spend less time with your family? Do you argue with your partner more? So those are some questions that they can answer, and it takes them through the steps of their behaviour. So when they have those feelings, what's the behaviour, and then what's the consequences? So it's a different way to approach acceptance. And what challenges might you face along the journey? What's your mind telling you at this moment? And quite often this might be, this intervention won't work, I've given up in the past, or this is too hard. And then finally, why do you think your mind is telling you this? And this will come back to what we said before about whether the mind not being your friend or your enemy, but it does what it does to avoid social rejection or avoid pain like you've had in the past. So writing down the thoughts can help them make some distance between them and allow them to see more clearly why the choices that they're making are coming up. So some of the belief barriers that we talked about before, I think we said this pain's been here for a long time, it's too complex. Was there any other ones that we said?
In terms of getting out of the pain,
Yeah.
it's too complex. I've been told I'm built this way, or something's not quite in the right place.
Yeah.
It's been going on for too long, maybe.
Yeah.
No one's been able to get me better.
Yeah.
Because,
Probably.
yeah, don't have the time.
Yeah. Yeah. Another one, medication doesn't help, so I don't see why anything else would. But yeah, that was most of the list, I think. So then you go through that notice, name, normalise, purpose and workability framework that we looked at before. So you can say, I notice that you're having these beliefs that you think will stop you from getting better. Normalise or validate their past experiences and say something along the lines of, a lot of patients sitting in the same position as you have similar thoughts. And then provide a purpose, so there might be a reason that your mind is telling you this. It wants to save you from feelings of disappointment like you've had in the past, save your time, save your energy, save your money, save you from taking a risk. But then there's a choice to make, so either we stop the treatment and we don't try it at all and things will continue in the same way, or you recognise the thoughts and feelings but continue anyway and see what progress you can make outside of that context.
Blue pill, red pill.
Again, and it comes back to, is that choice or that action taking you towards what you want or away from what you want? So if you stop the treatment without trying at all, it's taking you away, it's an avoidant behaviour because you're not trying anything new. or we take you towards and say, I want to live this kind of lifestyle, this might be the change that I might be able to do something even if the pain is still there.
It's like Morpheus, isn't it? We see how deep the rabbit hole goes.
What are your values? And where are we going with this?
Yeah. Then that question would reflect on values as well, wouldn't it? That would open up the conversation about values. Okay, cool.
Yeah. And reflect on them in a way that isn't judgmental. So their observing self can make a choice about their values. Do they want to continue that value or not? But it's not for us to say whether it's a good or a bad value. And another thing was to remember that with ACT, decreasing pain wasn't the goal. And for us, that can also be quite applicable in that the pain might not decrease, but it might take more for the pain to come on. You might feel stronger, get back to a specific activity, even though the pain hasn't completely disappeared.
So is that you repositioning the objective?
Yeah.
Okay.
I think with ACT, because you set from the outset that decreasing pain isn't the goal, it is different from here, because if someone wanted to deal with their pain in a psychological way, they might go to a psychologist in the first place rather than come here. With coming here, there is a certain expectation of what we will do physically to help them. And so I think it is something to tread lightly with, but it is something to consider that you might still see progress even if pain isn't changing.
I think it's still like it's such a good framework of understanding the patient's internal world. So just help us to understand foremost, and then navigating it would be a bonus.
Yeah, because I guess it kind of maps out how the values lead to like actions and how married they are to the goals, I suppose.
It's must be because of the results, like the idea of the ego, and ego being attached to these belief systems, which might be hooked. The ego might be hooked to a belief system which is counterintuitive to where the observing self wants to go. So that's everything. That's one thing that I was seeing.
Yeah, and then the kind of final element that they talked about was something called creative hopelessness. So this encourages patients to explore what hasn't worked in the past. And they didn't really explain why the concept was called that, but we kind of come to a conclusion with it. So I think that the concept is quite helpful when you're approaching patients with chronic pain or patients who are coming as a last resort, or they're quite cynical, don't have much faith in you or in us. So you would start by saying all the things that they've tried before. So you can suggest to them that you work in new ways as much as possible. So that could be physical things like exercises that they have tried before, treatment types that they've tried before, all the things that they've been suggested that haven't worked. And quite often they'll be avoidant of those approaches that have made no difference previously, so they won't understand why this time will be different. And again, just coming back to not judging the strategies, not judging if they're good or bad, positive or negative, just deciding if they're workable. So do they work in the long term to give you a way to live by your values? So some common avoidance strategies are represented by the acronym DOTS, D-O-T-S. So the first one, D, is distraction. So that might be socialising, scrolling on the phone to avoid doing the thing that they need to do or distracting them from doing it. I is for opting out, so avoiding people, places, situations or activities, so that might be procrastination. T is thinking strategies, so telling yourself that you'll do it later, imagining the future. And then the S is substances and other strategies like food, sugar, alcohol, smoking, medication. Others might be doing their hobbies or exercise. And again, these could be good or bad things, healthy or unhealthy things, but it doesn't really matter what they are, it just matters if it's taking them towards or away from their goals or living by their values. So quite often these patients with high levels of experiential avoidance and avoiding things will find that the pain comes back more often and at worse intensities. So they become more caught up in their pain or their beliefs about their pain, and they might miss out on more opportunities, which again will make them more avoidant. So the key point for those avoidant type presentations is helping them to recognise that avoiding pain isn't giving them the life that they want, it's not taking them towards what they want. And so what have you tried, how has it worked both long and short term, and what has it cost you, both physically and emotionally? And then going through the validation again, so you've tried your best to avoid the pain, so you're not framing them as lazy or avoidant, they've done their best to avoid pain, which is what they don't want. And you've done what a lot of people will do, so reframing something like, so they might say, when I look back at it, it seems like a really silly thing that I've done, but it's not silly, you've done quite a common thing. So, and some of those things can be beneficial in the short term, like taking medication, it takes the pain away, it takes you towards your goals, you're able to do an activity or do something that you need to do, but when that medication wears off, in the long term it hasn't made much difference.
It's bringing their awareness to that.
Yeah.
Almost like to create cognitive dissonance, because they're aware of how their actions don't match up to their objectives, that they'll then have to, a solution will have to be proposed. Okay.
To adjust things. And I think that's starting with all the things that they've tried before as well, make them feel listened to, make them feel heard, and also sets quite a clear baseline for you as a clinician of where to start with that. And then some other concepts, common beliefs that might come up with those patients is that they have become a victim of their pain, or they might not realise or observe that they've become a victim of their pain, but they might believe themselves to be through their actions, or victim of others, leading to inaction to address their thoughts and feelings. And quite often they will start to become, for example, anxious about the anxiety that they have about their pain, so everything becomes far more amplified, or the suffering increases. And they talked about the concept of dropping the struggle, so resisting the struggle against those things means that the anxiety might go up or down, but it won't become amplified by the additional level of anxiety about it.
Almost it's like a damage mitigator, like this is just to make sure things don't get out of hand.
It's more for them to see that when you push back or push against what you're having, or the thoughts and beliefs that you're having, that the consequences of them can become amplified. Alright. So again, I thought just as a final part, so the presentation, we could go through maybe a case again. So picked Mrs. P. She's 54, she's systemically well, she's got chronic episodic low back pain since childbirth 25 years ago, and 20 years ago she had an MRI which showed a slipped disc at L5S1. So I thought we could start off by talking about what her thoughts, feelings and beliefs about her back might be, what behaviour that might lead to, and what are the consequences of that behaviour.
So 25 years ago she had a child, and what happened 20 years ago?
She had an MRI which showed a slipped disc at L5S1.
So because trauma was involved, and because the trauma was large, I would hypothesise that she would think something has changed in her back, which is causing her pain.
Yeah. So she might describe her back as damaged.
Yeah.
What else might she think or describe
If I go
herself?
back to how it was, because that can't unhappen when it happened to her.
Yeah.
Yeah.
Like, things have never been the same since I had my son, which some people call my daughter, which is what I've heard quite a few times. Because it's been going on for so long, why would it change, or why would it get any better?
And what kind of behaviour might those beliefs or feelings lead to?
Avoid doing anything which might aggravate her back,
Yeah.
which could also be the things that make her back better.
Yeah.
Avoid challenges.
She might have stopped specific activities that she was doing before, like any sport that she might have been doing.
Sorry.
I was going to say, yeah, avoid again, same sort of thing, but trying new things or going on days out and stuff like that. So it might like affect her family life in a way.
Yeah.
Having children and so on, you kind of expect to be quite active and run around often.
Yeah.
Might affect them. So
Well, so that one thing that crosses over to like logotherapy and ACT is meaning, and I wonder if there is any meaning that she associates with her back pain, because it was so closely associated with the birth of her child. So I had this pain, but it was worth it because look at my like beautiful child or something like that, or I'm really proud of my son or my daughter, and then I suppose they could hook. That could be a hooking. So my ability to give birth to a child who I love is hooked to the damage that it has done to my back, and therefore to separate the two might get quite sticky, because you're then challenging her perception of motherhood, and her perception of herself experiencing back pain might be quite sticky.
And what kind of consequences do you think that could have for her for all the things we've talked about?
I can imagine it being everything that we've just discussed.
Yeah, or like specific.
Well, I would have thought that her idea of herself or her perception of herself could change quite a bit if she started to do things which took the pain away. You know, like the idea that it wasn't as bad as she thought it was can be quite a threatening belief system if she's sacrificed 25 years, if she felt like she's given everything to her son or everything to her daughter or everything to her home life, despite being in pain. If you then tell her that pain could have been gone 25 years ago, you just didn't do anything about it.
Yeah.
I can imagine that being quite a difficult
quite confronting thought to have. I thought that she might, like you said, she might be missing out on things. She might become a bit isolated or feel lonely in her social situation. Anything else?
maybe could be a case of that she doesn't want to get out of pain, because it allows for people to sort of do stuff for her, and it's a form of sort of affection to some people, like, oh yeah, I'll do that for you because you can't do that. But that's obviously like really breaking down really big hypothetical. But yeah, I mean, there are some times that those kind of behaviours, and sometimes people will only push just enough so they won't get out of pain.
You've seen that? That's interesting.
Every now and then. But not massively. It's just that, my son helps me with my shopping, so it's pretty good, so it's helpful.
Oh, okay, good.
Yeah.
Yeah, so I made a point of like man food the other day. Like a lot of guys aren't very expressive, so sometimes if you're not open to sort of love and affection, and someone's making you soup and everything, you might sort of put it on a bit and sort of say, oh, it affects you harder. But yeah, it's obviously a massive link that I'm just sort of hypothesized about.
Yeah, and I guess even in those situations, it would be to help them recognise if that behaviour is taking them towards their values. So a goal might be that they get out of pain, or they spend more time with their family, or they are able to participate in the things that they're currently missing out on. Is there any values that you think that aren't quite aligned with their goals in that situation?
In that situation?
Yeah.
I want to get out of pain Yeah, it looks like I want to be out of pain, I want to get better now to conflicting goals. The value, because the values might be, I don't like pain, and I like it when people care for me.
Yeah.
Are those two conflicting values?
So, I'm not sure if they would describe them as a typical value in that it's a thought or a belief rather than an action of how you approach something.
So values how you approach life.
Yeah.
Oh, okay.
Yeah. It's quite difficult to think of a value. I think that.
Like wanting to be independent from the pain, and
well, the value would be I'm independent.
Mm-hmm.
Yeah.
Is that right? Okay.
Yeah, to be or being independent.
The conflicting one would be this back pain runs my life, I suppose.
That's a thought, isn't it?
Yeah. I think because a value typically is more of a doing rather than a not doing.
Because that's like a corpse. That's a corpse issue, then, isn't it? Like I want people to care for me.
Yeah.
That's a corpse. That's a dead. What would you call it again?
So you want a live goal.
Yeah, that's
so
the
like
dead
a
goal. Oh, okay.
It's a bit more passive, so it's just like, how can I write some current to go through?
Yeah. So to be loving or to be supportive is a value, but to be loved and to be supported is a goal, because it's not how you're approaching. So to be loving or to be supportive is a value that you can live by, but to be loved, to receive it is a goal.
But then, okay, wait.
Because you're not passive, you're not actively approaching anything.
But would the value be I deserve love, I deserve affection?
That would be self-caring.
Would that not be a thought? Because I deserve love.
Yeah, it's an opinion.
Can values relate to what happens to you then? What about if a value is I don't deserve loneliness? Is that I don't deserve isolation? I hate isolation. Is that a thought or is that a value?
To be fair, it's a good question.
Yeah.
I hadn't really thought about whether that a value applies to you, because the context in which it was explained is that it's how you approach something. So it's
maybe
what
value
you actively do.
Okay. So then, what about value was I value social environment, so I value being around loved ones, and then if I can't actualise that value, that's when I'm now in distress. Is that right or no?
Yeah, I think so.
But then
I need to look up a bit more.
But then it would be, in an ideal world, the ACT therapist would help the observing self to observe the value, so then in the absence of actualisation of that value, the harm done to that person is more distant. Is that right? So they can observe it without feeling like they're in it, they're not hooked to it.
Yeah.
Oh, very cool.
Yeah, I think so.
Completely no. It's really like I get the utility of it, but it's properly like racking my mind.
Yeah. So I'm sitting here just overheating a little bit.
And then for the same case, I thought maybe we could attempt to set some smart goals for her. So like, this is at the end of our first appointment. What are we going to encourage her to do between this time and next, or what are we going to encourage her to do? Doesn't have to be like specifically rehab, but how are we going to encourage a value of self-care or of health or something like that?
Cool. So, do you want to go first?
Could you remind me what the SMART means in this context?
One sec.
Specific, measurable, achievable, realistic, time-based.
No,
it's slightly different.
Yeah.
It's only slightly different, isn't it?
It's motivated by value. Why can't I find it?
Oh, the M.
I think it's simple, motivated by values.
That's reading all of my notes.
Oh, here we go. So S is specific action.
Yeah.
Wait. I need to write this down. So one second. Sorry, go on.
N is motivated by values. A is adaptive, so make a positive or wise difference. R is realistic, and T is time framed.
I mean, with S&T, you could probably do together where you say, oh, if you just block out 5 minutes of your day for yourself or working towards getting out of pain, which might be a value.
Yeah.
What's the S again?
Specific action.
Okay.
Was it realistic?
Yeah. In line with your resources, time, energy, money.
Oh, I see. Well, yeah, is it realistic? Is that the 7 out of 10 rule?
Yeah.
Well, yeah, that's awesome to be fair, because a lot of the time people just say, oh yeah, you're telling me to do this, I'll go do it, and then they don't do it.
Yeah.
What's the A again?
Adaptive.
Adaptive?
Yeah.
Oh, okay. Okay, so you mentioned, so say if like we make up a value that she likes being around other people.
Yeah.
Yeah, so she likes to, I'm probably, I was writing this, I'm probably going to repeat exactly.
No, this is very different. Go on.
So specific action would be, and it needs to be under their control. So rather than see your friends, I need you to text or call one of your friends to meet up with them in a social setting, and then adaptive. Doesn't really matter what day it is or what setting it is. And then resources, making sure that it's affordable, make sure they've got time to do so. And then what's the T? Is that still time
frame?
Oh, there is still time frames. Okay. And then make sure you do that by the next time I see you, or else.
Yeah.
There you go.
What else? So I think it's quite a nice frame to make sure that the goals that we give are actually applicable and they actually will want to apply them if we make them according to, because we can provide the goal. I guess that's what we do when we give them exercises or advice to do at home. That's something that you can achieve to help you, as long as it fits in with what their values seem to be.
So would you come to a conclusion of a SMART goal with them, or from what you've said, this sounds achievable, what do you reckon? Would you sort of propose it, or would you sort of formulate it with them?
I think formulate it with them, but that's based on what they've presented to you from your interaction so far. Like, for example, if you do a rehab exercise with them that is too painful or too difficult for them to set up at home, is it 7 out of 10 likelihood that they're actually going to do it? Probably not. So you can effectively pick and choose something that you can put together for them for advice at home, and then present it to them and say, this is what I suggest, and then double check them and debrief with them, do you think that this is something that you'll do? Rather than it all just coming from you. Because if it was all coming from us, we might give them the 3 exercises that are anatomically right for what we think their problem is. But if they don't address the things that we want them to address, then will they see the motivation to do them? That's if you're saying anatomical rehab.
Yeah, of course,
so that was the PowerPoint.
That's awesome.
Any
Love that.
questions?
There's some techniques which overlap with mindfulness. So once again, is that just to reinforce the observing self over?
Yeah. Mindfulness in the sense that they are very aware of. So you've got the awareness, the thinking self, and then the observing self.
Okay, sweet. Wicked.
And you basically sort of associate a separate action to the pain in our context. Is that, like, from my understanding of it, is that what we're kind of trying to achieve? So you're kind of accepting, what's the again? I'm talking about the engagement, really.
Oh yeah.
So you're sort of, you're engaging with it. So I don't know, pretending you're playing the piano or something if your knee hurts. That kind
Yeah.
of thing? I don't know.
With
Like,
the acknowledge, connect, engage, yeah.
Yeah. So like, oh, my knee's flaring up again. I'll just pretend I'm playing the piano or something. Or
That's a distraction, isn't it?
It is a distraction, but it is also connecting with your body and using and moving your body in a way that's comfortable.
So it's almost like because it's going towards your goals still. Like there's a distraction, but it's going towards your goals.
Yeah, but it's going towards a short-term goal, not a long-term goal.
yeah.
So it's not necessarily helping you live by your values,
Yeah.
but it might be helpful short-term.
I see. So you're kind of acknowledging, okay.
Like body scan meditation.
Yeah, exactly. Yeah.
Yeah.
Oh. Oh, sweet.